This is 306 Assessment 2 presentation by Megan Cant. Restrictive practice, according to New South Wales Health, involves any intervention with the purpose of restricting the rights or freedom or movement of a person. More specifically, restrictive practice is split up into physical restraint, pharmacological restraint, and environmental restraint. Physical restraint includes hands-on immobilization or restriction of motions by an application of a device. This can include lap belts, bed rails, tip-back chairs, and posy restraints. Pharmacological restraints involve the administration of medication with the purpose of restricting a person's movement. This includes anxiolytics, hypnotics, neuroleptics, and sedatives. Environmental restraints involve the restricting of a person's free access to all parts of their environment. This can include, but is not limited to, locking doors and removing objects with the ability to cause harm. The problem with restrictive practice is a comparison between the high rate of adverse events and the low rate of positive patient outcomes. There are various adverse physical, psychological, and legal impacts that can occur as a result of restrictive practices. This can include functional decline, pressure injuries, feelings of shame, or intergenerational distrust of medical staff. A focal issue with restrictive practice is that we are creating a power imbalance between staff and consumers, especially amongst the elderly population. By creating a large power gap, we are inviting issues surrounding misuse of power. This can result in abuse, assault, and battery. The strategy presented today will surround the concept of involving family and friends in the active treatment of consumers. The main reason consumers are restrained is because they are deemed as aggressive or non-compliant. However, it's been shown that by engaging family and friends in care, we can increase compliance and decrease aggression. This is supported by evidence that has shown that by implementing person and family-centered care, consumers experience lower mortality rates, decreased rates of readmission, decreased lengths of stay, increased adherence to treatment, and improved functional status due to increase in health literacy. By involving family and friends in care, we are not only decreasing the need for restrictive practice, but also empowering individuals with information and the right to make their own decisions. This aligns with not one, but two of New South Wales Health's core values. By involving family in care, we are able to simultaneously empower both consumers and relatives, as well as facilitate collaboration. This enables us to educate more Australians with regards to health literacy, introduce elements of care most important to the patient, and encourage a positive approach to healthcare. Rather than restraining and restricting individuals based on our beliefs, we should be asking those who know them best. Here I have my references that I have used throughout this presentation, and that concludes the presentation. Thank you.